going to get a recording in progress. Okay, then. I'm going to get rid of this checkbox like this. Okay, excellent. Okay, so somebody is still waiting, Nimali. Somebody called Clint. There you go. Hi, so I'm just going to introduce myself first. So my name is Kipyo Sen, and I was graduated from University of Medicine, Manly in 2012. And at the minute, I've taken time out of training from neurology specialty training year 5 to do research at University of Birmingham. So I thought I would deliver this lecture. Well, not lecture, I would just say like discussion in English, because I really want you all to get used to attending lectures delivered in English, because I believe you are as brilliant as medical students here in UK. So I will also be exactly giving the same lecture to medical students here, okay? So today I'm going to discuss, I'm not going to teach you because you can read about this topic or about conditions on internet, okay? So from whatever resources you have, textbook, whatever. So I'm just going to discuss about this topic today rather than like teaching. And it's going to be very much interactive, and I do have methods for that. So stay tuned. So I'm just going to talk about some relatively common conditions and some conditions which aren't that common but treatable, so you shouldn't miss those. And I'm also going to talk about some conditions that can present like acute neuromuscular weakness, but actually it isn't. And this is not going to be an academic talk. Like I said, you have a lot of resources, you can read about those topics, thousands of articles. So I'm just going to focus on approach and management from a junior doctor point of view. When you become graduated, when you're going to start working as a junior doctor, how are you going to manage when you see a patient presented with acute neuromuscular weakness? So before I start, this is the very basic, and I understand you all are final year medical students, am I right? So I guess you all have been taught about this, but this is a little revision with me. So when we want to differentiate whether it is due to central nervous system problem or peripheral nervous system problem, so we will look at 3 parts. So the first one is motor system. And we all know that in upper motor neuron lesion, everything is going to be increased, tone is going to be increased, deep tendon reflexes is going to be increased, plantar response is going to be upgoing. And in lower motor neuron lesion, so everything is going to be decreased, so except muscle fasciculation. So you're going to see an additional feature in lower motor neuron lesion, that's fasciculation, okay? So that's a rule of thumb. There are also some exceptions, but I'm not going to talk about that. And in sensory system examination, if a patient presents with sensory symptoms only on one side, and then that's likely to be central nervous system problem. If it is like multifocal, and then we'll think about peripheral nervous system problem. And if a patient complains about pain, and we'll think about peripheral nervous system problem. However, there's some exceptions. For example, thalamic lesions. So thalami are deep structures, okay, so structures that are located deep inside the brain, so central nervous system structure. However, when thalamus is involved because of stroke or because of tumor, etc., what you're going to see is a patient presenting with significant pain. And another exception is neuromyelitic optic spectrum disorder. So that's central nervous system demyelinating disorder. So although it's central nervous system problem, Again, in that particular condition, patient can present with painful spasms. And the last part that we're going to look at to differentiate whether it's peripheral nervous system problem or central nervous system problem, it's going to be sphincter symptoms. So if patient has bladder bowel issues, so mainly urge incontinence and urgency, urinary frequency, urgency, etc., and you'll be thinking more towards central nervous system, then peripheral nervous system problem, usually you don't see urinary symptoms of bladder bowel problems. However, there is an exception. So one, sacral nerve roots are affected, so we call sacral radiculopathy. So in that case, patient can have voiding symptoms. Patient will have difficulty to empty bladder, and they can present with urinary retention or overflow incontinence, etc. So that's very basic about discussion today. And I am going to clarify a bit about the topic. So when we say acute neuromuscular weakness, one, will you say patient is presenting, a patient will present with acute neuromuscular weakness. So we'll say subacute or acute, when the onset of the symptoms are within 6 weeks. And when we say neuromuscular weakness, if any part of lower motor neuron, neuromuscular junction, or muscle is affected, and then we will say neuromuscular weakness. So when we say lower motor neuron, and then we know that lower motor neuron will start from anterior horn cells in spinal cord, and then the axon will come out in ventral ramus, and that will form a nerve root. And when that nerve root is affected, and we call radiculopathy, and then the nerve will come out, and then the nerve terminal sort of will synapse, fire neuromuscular end plate to muscle, and then fire that neuromuscular junction. So neuromuscular transmission will happen, and the message will be relayed to muscle so that the muscle can contract. I'm just going to pause here for a few seconds and ask the audience, is the pace all right? Am I going too fast? Well, you don't really need, I mean, if you're shy, you can just text in chat. Can you teach in Burmese? Okay. What about other people? Oh, okay. Somebody asked me if I can teach in Burmese. I'm just going to ask for a quick sort of like vote. So if you want me just to, you see, do this discussion in English, I want to learn in Burmese, okay? That's okay, okay. Yeah, any more people? Yeah, so I will look at the majorities. It's democratic system, isn't it? So if it's okay, English, please. English, please. Okay. Any more? Okay, so what I will do is I will slow down a bit, and it's really important. I mean, you will also know that I'm not perfect and sort of like talking in English, but I'm also trying my best, and you guys should also try. Okay. So just try to follow it. It will be difficult at the beginning, but you'll get there. Okay. So I will slow down a bit. Okay, but because majority sort of wanted to continue in English. Okay. So excellent. Okay, fine. So I'm just going to get rid of this text box. So now a little bit of interactive session. Okay. So I would like you all to text one condition each that can affect anterior horn cells, nerve roots, and/or nerves, nerve ending, neuromuscular end plate, or muscle. So it doesn't really matter if you cannot give me the right answers. I just would like to know your sort of like baseline knowledge. So some people might be bookworms, so might be able to answer all the questions. So I don't really mind, but I just would like to know what the majority is like about this topic. So I'll give about like 2 minutes. So any condition that you have heard that can affect anterior horn cells, nerve roots, nerve ending, neuromuscular end plate, and muscle. Yeah, I've got one entry now. Spinal cord tumor. If that tumor just only affects anterior horn cells, perhaps. Yeah. Excellent. Somebody mentioned about polio. Perfect. Lateral sclerosis is mixed. Yes. So motor neuron disease. Yes. I mean, it can give a mixture of lower motor neuron lesion as well as upper motor neuron lesion. So I can buy that. Yes. Myasthenia gravis. Excellent. Syringomyelia is a mixture. Radiculopathy. Excellent. Any takers? Have you heard anything that can affect muscle? Stroke is central nervous system problem, isn't it? Columbury syndrome. Motor neuron disease, yes, some variants can only cause lower motor neuron lesion weakness. Yeah, progressive muscular atrophy. Excellent. Lambert-Eaton syndrome. Okay, perfect. Oh, I'm really pleased. Yeah, that's why I tell you, you guys as brilliant, perhaps you seem more brilliant than medical students here, okay? So I'm just going to crack on, okay? Now, case one. So it's going to be interactive session, okay? So you really need to stay awake. So the first case, a 32-year-old gentleman with nil background medical conditions presented with 5 days history of pins and needles in his feet, which gradually went up to his knees and then thighs, followed by weakness in his legs. He didn't come to hospital straight away because, as you know, we live in this COVID pandemic. So he waited for a bit. And today he woke up and then he had a fall. He couldn't get up. He couldn't walk. And he also started developing pins and needles in his hands. So history. So from history, about 85%, 80% of the time we'll get a diagnosis, okay? Then we take a little bit more history, and then this guy gave history of stomach upset. So nausea, vomiting, abdominal pain, and he also had a bout of diarrhea. So when we do motor system examination, so everything is reduced, okay? Tone is reduced, deep tenor reflexes are globally absent, planters were downgoing, and he had significant weakness in his lower limbs, worst distally, okay, slightly better proximally, and in upper limbs, and again, he has more severe distal weakness, so finger flexion, extension, wrist flexion, wrist extension. So, and they were also weak in shoulder abduction, adduction, elbow flexion, extension. They're also weak. In lower limbs, the weakness is more severe. So, could you type in the chat box whether you think this is upper motor neuron lesion or lower motor neuron lesion? Okay. Oh, Okay, so before we jump to the diagnosis, okay, so we need to localize first, okay? In neurology, when we approach a problem, we're trying to localize the lesion first, okay? Whether this is central nervous system problem, peripheral nervous system problem, and when we have localized, and then we're trying to look for the etiology, okay? Excellent, lower motor neuron lesion. Okay, so how am I going to get rid of this admit thinking? Okay, excellent. So we do sensory system examination. Sensory system examination was unremarkable. So if we summarize the findings, yeah, this patient has acute or subacute because the onset is within 6 weeks, and he has symmetrical and progressive lower motor neuron lesion weakness with subjective sensory involvement. He doesn't have any motor involvement, okay? So now you want to type the etiology. So what do you think is going to be the most likely diagnosis here? Excellent. Okay. Perfect. Yes. So we will be thinking about Columbury syndrome. Okay. So medicine is most of the time about pattern recognition. Okay. Pattern recognition. When you see a patient with acute, progressive, flaccid, or lower motor neuron lesion pattern weakness, you will be thinking about Columbury syndrome, okay? So Columbury syndrome, for those who do not know about this condition, okay? So it is, you can say like it is an autoimmune condition, okay? So autoimmune condition means like your body's immune system tries to attack own antigen, okay? So in process of like trying to get rid of infection, when bugs enter, the body's immune system sort of like tries to sort of attack the bug. And during the process, it also attacks self-antigen, okay, body's own antigen. So in this case, it is myelin, okay? So this is a wire. So the nerve is like a wire. You have myelin, okay, so outer layer. That's for the speed, okay? And inside the wire, so it has copper. But inside a nerve, it has nerve axon, okay? So myelin and axon. So this condition mainly affects myelin, okay? So it will attack myelin, and then what's going to happen is there will be loss of myelin, and then the speed of conduction along the nerve is slowed down, okay? So that's how a patient sort of like presents with progressive, okay? And because peripheral nerves are involved and you're going to have lower motor neuron lesion type weakness. Now you're going to ask, is it dangerous? It really is, because it can affect cervical nerves, okay? Cervical nerve roots 3, 4, and 5. So that supplies the strongest muscle in the whole body, which is diaphragm. So when diaphragm is involved, what's going to happen is you won't be able to, inhalation, inspiration, let's say like inspiration and expiration. So what's going to happen is there will be hypoxia, there will be carbon dioxide retention, and you're going to have type 2 respiratory failure. And that's really, really dangerous, isn't it? And it can also affect autonomic nervous system. So patient can have tachycardia, arrhythmias, etc. So my point is, it is a deadly condition, okay? There aren't a lot of emergencies in neurology, okay? And this is one of the emergencies, neurology emergencies, okay? So that's why it's really, really important for you guys to know about this condition. Investigations to aid diagnosis. So it is most of the time a clinical diagnosis, okay? So when you know the history, you know that this is going to be Columbury syndrome. but you can do some investigations sort of to complement the diagnosis. So one examination is CSF examination. So what you're going to find is CSF protein is going to be high, but you don't see any increase in white cell count. So, and then we call it cytoalbuminous dissociation. So that's the difference between, for example, like infection, so infectious radiculitis, so, or malignant infiltration of the nerve roots. So in that case, you're going to see high white cell count. But in this situation, you're not going to see that. White cell count is normal, however, protein is high. So there is dissociation between the cell count and protein level. So that's why you call cytoalbuminous dissociation, okay? And I also mentioned before that your immune system attacks own antigen, okay? So ganglioside, so that's the component of myelin. So antibodies to ganglioside can also be checked. It is not mandatory, but you can check if you have resources, okay? It can also help predict prognosis as well by helping in categorizing the variant. And you can do nerve conduction study, electromyogram. So it's essentially the study of the speed, okay? And the output from the nerve stimulation. So I'm not going to talk about those in details here, okay? So, and the second part of investigation is to look for complications and to monitor. So 12 leads ECG, it's a very simple but very important investigation in this condition. So you really need to have a 12 leads ECG because patient, like I said, patient can have autonomic nervous system symptoms. So in that case, if you don't have a baseline ECG, how are you going to know? You see whether the patient already had arrhythmias, already had heart block, etc. Okay, so 12 weeks ECG as baseline. Patients should be on continuous cardiac monitor, and then you do forced vital capacity. Okay, so I have shown a little handheld machine here. Okay, you blow into it, and then you will have the value. So these days we have Mr. Google. Okay, so you don't really need to remember every parameter, every paragraph by heart. But sometimes you really need to know those parameters. Is mandatory. Okay, so those parameters are really important. Okay, especially when you become a junior doctor, when you're going to look after those patients, those parameters, you really need to have a look at those regularly. Okay, so I would suggest you write it down. So if forced vital capacity is 20 ml per kg, okay, at or below, patient should be in high dependency unit. However, if patient's forced vital capacity is 15 ml per kg, okay, or below, patient is at imminent risk of type 2 respiratory failure and will need intubation and ventilation very soon. So I'm going to give you a little exercise, okay? So let's say patient's body weight is 65 kilograms, okay? Now, type in the chat box of those calculated values, okay? One, at which forced vital capacity patient should be in HDU, and at which forced vital capacity patient is likely to need ventilation, okay? So patient's body weight is 65, okay, 65 kilogram. At which forced vital capacity you will move the patient to HDU, and at which forced vital capacity you'll be considering like ventilation. Excellent. And at which value you think patient is likely to need ventilation. Perfect. Okay. Excellent. Excellent. Okay. So great. So next. So how are you going to manage? So if you have a patient with AIDB or GBS in your ward, you'll be closely monitoring his or her vital signs and forced vital capacity. And management is intravenous immunoglobulin. So intravenous immunoglobulin is, to be honest, we have been using it in treating neurological conditions for a while. We don't really know the exact mechanism of action, okay? But there are lots of like hypotheses. So essentially, so those immunoglobulins can bind to sort of pathological antibodies, okay, that the sort of like the culprit antibodies, and then those will be removed from body. That's one popular proposed hypothesis, okay. And the second one is those immunoglobulins will modulate your immune system, okay. So that's how the condition is treated with this intravenous immunoglobulin, not in just this condition, in other similar conditions as well, okay. So plasma exchange is like something similar to hemodialysis, okay, not the same. So what it does is it will wash out all the bad antibodies from body, okay? So we give intravenous immunoglobulin. Sometimes patient will get better, so you don't really need to give another treatment. But in some patients, they do not get better, and in that case, you consider plasma exchange. There's no role of steroids in Columbury syndrome management, okay? Now, when you say IVIG, so I should also perhaps let you know about this, okay? This is the current clinical practice in UK. So, so intravenous immunoglobulin has been shot worldwide, and especially in UK because of risk of CJD. So we cannot sort of like use pooled plasma. So when you want, so intravenous immunoglobulin essentially is produced from a pooled plasma. So pooled plasma means you collect plasma from, okay, thousands of people, and then you sort of like extract immunoglobulin, okay, and that's used to treat different conditions. Because of risk of CJD, we don't sort of like we cannot produce intravenous immunoglobulin here, so we have to sort of like get from EU or other countries. So for neurological conditions or other immunology related conditions, so we have other alternative treatments. For example, we have plasma exchange, we have let's say rituximab, we have steroids, we have other alternatives, quite a few options. But there is a subset of patients who rely totally on intravenous immunoglobulin. So those are the patients with immunodeficiency syndromes. So because there is shortage, it's not even because of cost. So we really think twice, sometimes 3 times, if we're going to prescribe intravenous immunoglobulin. And we look at sort of like 2 guidance. So one is from Department of Health. So this one, I'm not sure whether you'll be able to see this. Okay, so it's from Department of Health, clinical guidelines for immunoglobulin use. So essentially all the conditions will be given either red, blue or gray the colors, so color coding system. So if that condition has the red color coding, that means you don't really need to go through immunoglobulin panel, so you can just give it straight away, okay, as long as patient meets criteria. If it is blue, patient will need to go through a panel to get approved, but it's likely to be approved. And if it is gray, and it is very unlikely that that condition is going to be approved by the panel to be able to use intravenous immunoglobulin for that patient, okay? And this one is, again, another important document. So in UK, we have different NHS trusts. So they get money from government, okay? And they have to sort of like, they have to show a list of like cost for everything they use for patients. So if they don't use intravenous immunoglobulin properly, okay, according to this, as per the guidance. So what's going to happen is the department itself, for example, my department, didn't use intravenous immunoglobulin properly according to this guidance, and then my department will have to pay for it on its own, go on from its own funds. So that's not good, okay? So this is just a sort of like a taster, let's say taster, yeah, about system clinical practice in the UK. So here, as you can see, Columbury syndrome has red color coding, so you can just go through it as long as patient meets criteria, okay? So you can read about those. So essentially, if patient cannot walk, patient is wheelchair dependent, okay, so at presentation, definitely patient will need Columbury syndrome, okay? Sorry, intravenous immunoglobulin. And when we consider prognosis, okay, because patients are going to ask, what's going to be my prognosis? So 85% of the time, patient will get complete recovery by 1 year, okay, by 1 year. It's going to be poor if patient had Campylobacter infection, like diarrhea, dysentery, nausea, vomiting, etc. at the onset, and that is likely to be poor because it is associated with axonal injury. Okay, remember the wire, okay? So if the myelin is affected, it is easy to be repaired. If the copper or axon is damaged, okay, or you see dissected, and what's going to happen is prognosis is going to be poor. And again, the muscle scoring, because we call Amigo score. So it's a combination of like subscores, but the main score there is muscle weakness. If muscle weakness at onset is quite severe, or a while later, the muscle weakness, you see, will get worse and worse. The worst point, okay, the muscle weakness is quite bad. And again, it's going to be quite poor. And when a patient sort of like reach to nausea, so the worst point, very soon, and that's not going to be good. And if there is evidence of axonal injury in nerve conduction studies, and it's also not going to be good. So variance, Columbury syndrome, so that's a typical presentation that I mentioned earlier. So acute progressive sort of flaccid weakness. There are also variants, like I said, mainly it affects myelin, but it can also causes axonal injury in the first place. And I have highlighted this condition in yellow, Miller-Fisher syndrome. The reason I highlighted is it is a very common question in MRCP, okay, it's MRCP exam. So that's a little sort of mnemonic that I use. So it's a frog. So Miller-Fisher syndrome is a frog. So it is areflexia, optimoplegia, and ataxia, and then you think about this syndrome, okay? And there are also other variants. Patients can only have pharyngeal, cervical, and arm weakness, and then we call PCB variant. Some patients can just present with sort of facial weakness, okay, bilaterally. So we just had a patient with facial diplegia. So facial type is a big name, but essentially saying patient presented with bilateral facial weakness, lower motor neuron lesion, preceded by COVID vaccine, okay? So COVID vaccination is also a trigger for GBS. And there are also other variants, you see, you might not be very much interested. So let's say if this patient, in this scenario, if patient became confused, okay, on your watch, okay, the patient became confused, what would you think? Okay, yeah, you can type in the chat box. Yeah, patient, you see, while he was on the ward, let's say he would like get confused. Or what would you think? What thought would come into your mind first? Hypoxia. Okay, great. Hypoxia. Okay, when you say hypoxia, there are two types, isn't it? Type 1 or type 2 respiratory failure. So which type of respiratory failure you're going to see here? Type 2, yes, excellent. So yes, patient is going to have type 2 respiratory failure because you see, like I said, diaphragmatic palsy can lead to type 2 respiratory failure. So there will be carbon dioxide retention, okay? So carbon dioxide narcosis, and patient is going to be confused. would definitely think about sort of carbon dioxide retention, type 2 respiratory failure. And there is another condition that, again, it's very interesting if you're going to be a neurologist or if you're interested in neurology. This is quite an interesting condition because it's quite different. Yeah, it's quite different to usual like sort of presentation of Columbury syndrome. So patient will have ANTV pictures. Essentially, patient will have flaccid weakness, but they also have some brainstem signs, okay, eye signs, or some like extensive outgoing planters. A patient will be confused, and then you'll be thinking about this particular variant called Baker-Stepp's brainstem encephalitis. Okay. Now, case 2. Okay, so 82 male. He presented with sort of like difficulty to come and rise from chair for about 6 weeks, and right eyelids sort of like has been drooping for a while, and he has been seeing like devils everywhere for about 4 weeks. Speech has been noted to be a bit slurred by family members for about 3 weeks. All symptoms you see became the worst at the end of the day. And he had a few choking incidents in the past 2 weeks, okay? And he was admitted to emergency department with breathlessness, and you happen to be, let's say you happen to be a junior doctor there. So what are you going to do? You're going to do examination, and patient will have bilateral partial ptosis, okay, the ptosis. And when you check, you see optimoplegia in H shape. Patient had binocular diplopia everywhere, okay, binocular. So if it is uniocular, yeah, uniocular diplopia, and that is likely to be intraocular causes, okay. If a patient has binocular diplopia, and then it's going to be extraocular muscle problem, okay. So we say complex optimoplegia. So this term, you're going to hear it a lot when you prepare for PACEs, okay. So one sort of popular PACE question is causes of complex optimoplegia. So complex optimoplegia means so you cannot pinpoint to any of like third, fourth, sixth cranial nerve palsy or combination of those. You don't really know what's happening. You don't think this is like the third, fourth, and sixth cranial nerve palsy, and then you call complex optimoplegia. And patient had fatigable dysarthria and dysphonia. We say fatigable, so that means at the when you start talking to patient, speech was all right, okay, but at the end of the sort of like consultation, at the end of history taking, his speech became slurred. And the way to check is you can also ask a patient to count aloud from 1 to, let's say, like 30, and then you will notice that his speech became like slurred, and then the voice will become like softer and softer. And fatigable weakness of limbs, the way we check is you ask the patient to do like shoulder abduction, adduction for about 20 times. So remember, patient is 82, okay? So you also do like this kind of like repetitive movements at the same time, and then you check with the same sort of like side of like upper limb. The reason being is if you don't do it and you just check with your force, and if let's say if a patient is a tiny sort of like elderly lady, and you might think, oh, patient has fatigable weakness, but actually not. Yeah, so you need to compare your power with patients, okay, always. And deep end reflexes were normal. So working diagnosis, again, interactive section. So what do you think? What do you think about diagnosis? Ooh, oh, wow. Okay, excellent. Wow, wow. Okay, that's why I'm telling you, this group is more brilliant than medical students here. Excellent. Okay, I'm very happy. Yes, myasthenia gravis. Okay, so again, it is an autoimmune condition. So the picture here, okay, shows motor nerve terminal. Okay, here, motor nerve terminal. And this is neuromuscular end plate, and this is muscle, okay? So when action potential comes to the nerve terminal, what's going to happen is, yes, finally, the acetylcholine receptor vesicles will be pushed to the presynaptic membrane, and acetylcholine will be released to the nerve junction, and they will bind to acetylcholine receptor, and then the message will be relayed to the muscle to cause contraction. That's how it works normally. But in myasthenia gravis, what's going to happen is in 85% of the time, there will be antibody, okay, so that will bind to this acetylcholine receptor. And the message cannot go through this neuromuscular junction, okay, to the muscle. That's why a patient has weakness. So one patient has fatigable weakness. So of course, it's the same. To be honest, it's the same physiological process, isn't it? When you wake up in the morning, okay, you're very fresh, yeah, like you all, yeah. Oh no, actually, you say it's afternoon, isn't it, in Burma? But let's say like for me. So when you wake up in the morning, you're very fresh, you're very strong. But at the end of the day, and after a busy on call, you don't even have any energy to wash your face. Okay, this is normal. It's much worse in patients with myasthenia gravis, okay, because at the end of the day, they don't have any acetylcholine left, okay, in the nerve endings, and as well as neuromuscular junction. And they also have antibodies, you see, binding to those acetylcholine receptors, okay, so that's how they have this fatigable weakness, okay. They will say like, oh, in the morning, I don't have any ptosis, I don't have any drooping of the eyelids, but at the end of the day, I cannot even open my eyelid, and then you know that this is fatigability, okay? And there's no autonomic nervous system involvement, but the reason why I mention is there will be another similar condition where there will also be autonomic nervous system involvement, but yet this is still a dangerous condition because of, like I said, diaphragmatic palsy and you see respiratory muscle palsy, okay? Investigations, you check for basic bloods and all the neuromuscular weakness cases, you should check thyroid function test and as well as creatinine kinase. And you check for anti-acetylcholine receptor antibodies, as well as if needed, you can also check muscle-specific kinase antibody and anti-LRP4, yeah? Because the antibodies can also attack this muscle-specific kinase and LRP4. So, and you do repetitive nerve stimulation, okay? It's kind of like trying to reproduce fatigability. So you stimulate the nerve, okay? So this is the nerve, this is the muscle. You stimulate the nerve repetitively, and then to exhaust, you see the acetylcholine release. And then what's going to happen is when you test again after you see repetitive stimulation, so the output, okay, the output from the nerve is going to be significantly reduced, and then we call decremental response. And it can also be paraneoplastic condition. That means it can be associated to a malignancy, okay? So mainly thymoma can also be related to thymic hyperplasia, etc. So you do CT thorax with contrast to check for thymic abnormality. So management wise, okay, now another short interactive session. Can you recall the values? Okay, one, will you transfer this patient to HDU? One, do you think patient might need ventilation and intubation? Okay. 20 ml per kg HDU. Okay, what about impending type 2 respiratory failure, ventilation? Oh, perfect, perfect, excellent, well done. So 20 ml per kg, you should really sell this patient to ITU. Tell them, look, this patient is going into type 2 respiratory failure. Please take this patient, please take this patient. Okay, don't leave the patient on the ward, okay? 15 ml per kg, definitely you should really sell ITU, okay? To consider ventilation and at least use very close monitoring, okay? So then again, similar treatment, IVIG, plus minus change. You can give prednisolone. You can also start pyridostigmine, okay? I'm going to talk a little bit about pyridostigmine, okay? So this acetylcholine here, okay, after they have done their job, okay, what's going to happen is they will be metabolized by acetylcholine esterase enzyme, okay, to acetic acid and choline. So in myasthenia gravis, we have like sort of less supply of acetylcholine, isn't it? So we want to work them a bit harder. So what we do is we block this enzyme, okay? Reversibly block, okay? Block this enzyme so that we have increased availability of acetylcholine there. Okay, that's how pyridostigmine works. Quiz, okay, a quiz to you. Do you know, okay, irreversible choline esterase inhibitor? Okay. When I was a medical student there, I really need to know about this irreversible choline esterase inhibitor. Okay. If you don't know about it, you fail the exam. It's a very common poisoning, okay, in Burma. Maladian. Ah, perfect. That's why I'm telling you, so this cohort is very brilliant, this cohort of medical students, okay? Yes, so but when you have choline, increased acetylcholine, okay, at neuromuscular junction, what's going to happen is you're going to have increased muscle contraction everywhere, okay? So one side effect that's going to bother the patient is increased GI and gastrointestinal muscle contraction, okay? So sometimes that side effect that patient will have to die, but you can offset that, you can minimize that by adding this propendylene. So this is sort of like relatively selective anticholinergic, okay? So if patient is having significant gastrointestinal upset, and then you can give this propendylene, okay? So again, when we think about giving IVIG in UK, you look at those two guidelines, okay? And myasthenia gravis, it's a blue, okay? It's a blue indication. So that means you have to discuss at the panel and you have to tick all those criteria. Patient will need to have diagnosed myasthenia gravis and either acute exacerbation or weakness requires hospital admission or prior to surgery and thymectomy. And the dose is also not the same. The standard dose is 2 grams per kg. And this is not very updated. So this CCG guideline is more up to date. So you give 1 gram per kg, just half dose, and have a look. If there's no improvement, you give another 1 gram per kg. Okay. Now case 3. Okay. Now it's like playing games. So like we go one step after another. The difficulty will get harder and harder. Okay. So case 3, 65 female, heavy smoker with 80 pack year smoking history. Okay. When you say something when you report something to senior, for example, smoking history, you cannot say just heavy smoker. Okay. You really need to be objective that you use this term, isn't it? Pack years. Okay. Pack years. If you go, yeah. So pack year means how many cigarettes per day divided by 20 into years. Okay, so this lady, she has been smoking for at least like four cigarette packs. Yeah, 4 cigarette packs. I don't know. I cannot calculate that. Well, I don't have time at the minute to recalculate how many cigarettes per day, but she's a heavy smoker. Okay, and she presented with difficulty to comb hair and use stairs for about 4 weeks. She finds difficult to swallow, and she also reported about this dry mouth. Her mouth has been really dry, and she reported about significant weight loss of about 2 stones, which is about 15 kilograms, and her body weight prior was, let's say, like 70 kilograms. So that means more than 10% loss, about 20% loss. That's significant. Okay. So, and what are you going to do? So when you see this patient, okay, let's say in acute medical unit here, you're going to do examination. You do sensory system examination, normal. You do motor system examination, tone is normal. Muscle power, she has proximal weakness. So proximal weakness means shoulder weakness, adduction weakness, hip flexion, extension weakness. They're weak. Deep tendon reflexes were absent. Yeah, absent. When you do bicep jerk, it's absent. But what you do is you ask the patient, okay, to do flexion and extension of elbow for about, let's say, 20, 30 times, and then you repeat, okay, deep tendon reflexes again. And what's going to happen is it reappears, okay? And planters, downgoing, and cranial nerves. So her speech was definitely slurred. Okay, so if I have to summarize, this lady presented with sort of, again, subacute, acute, progressive weakness involving girdle muscles, okay, shoulder and hip muscles, and what else? Oh yeah, so she also has some bulbar symptoms, so dysarthria, dysphagia, okay, and she has some autonomic nervous system symptoms, dry mouth, and she's a very heavy smoker with 80 pack year smoking history, and there is also weight loss. Okay, so that's a summary. What do you think is happening here? Oh man, yes, lungs. Excellent. So we'll be thinking about Lambert-Eaton myasthenic syndrome. So I'm just going to talk about it a little bit again. Okay, so like I said, one action potential, okay, reaches to the end of the motor nerve terminal. What's going to happen is it's going to stimulate this voltage-gated calcium channel, and the calcium will come into the cell, okay, the nerve ending, and this calcium will push the acetylcholine vesicles to the presynaptic membrane, and then acetylcholine will be released, and then they will bind to acetylcholine receptor, and then the message will be sort of relayed to the muscle. But here what's happening is in Lambert-Eaton syndrome, there will be antibodies to voltage-gated calcium channel. Okay, so this process cannot happen because of the antibodies. That's why patient has weakness. And in this case, yeah, so patient initially didn't have any reflexes, but after repeated stimulation, they reappear, and then the proximal muscle, okay, after repeated movements, become stronger. So in that case, so that happens because, yeah, so when you ask patient to do repeated movements, so essentially you're trying to stimulate the nerves by sending lots of like action potentials. When there are a lot of action potentials, what's going to happen is that will overcome the antibody, and then voltage-gated calcium channel will work, and then you see the message can be sort of like relayed to the that's why you see it get stronger. Okay, they get stronger after repetitive muscle movements. Now you're going to ask me, okay, and then why this patient develops antibodies to calcium, voltage-gated calcium channels? There are two reasons. One is we don't really know it. The immune system, you see, becomes like dysregulated, and it starts attacking the own antigen. And an unfortunate thing is the voltage-gated calcium channels. In majority of cases, in 60%, it is paraneoplastic, and it's commonly associated with small cell lung cancer. So paraneoplastic syndrome in concept is a person's immune system is very vigilant about cancers, okay? So one immune system detects like even a teeny tiny tumor, it is very like sort of like strong in attacking those tumor cells. So it has good intention, isn't it? The good intention is to get rid of tumor cells. However, as a result, what can happen is it can also attack self-antigens, which are similar to tumor cells. So that's how a patient has paraneoplastic neurological syndromes. You see, one, they started to have cancer. The good thing is, from cancer point of view, they have good prognosis. Bad thing is, they have to bind this paraneoplastic syndrome. So what's going to be the treatment? Yeah, treatment is going to be very simple. Oh, I need to talk about these clinical features first. Okay, but I have already told patient will present with girdle weakness, bulbar symptoms. Okay, there will be absent reflexes, but there's a very characteristic feature of this syndrome, which is reappearance of symptoms on repeated exercise. Okay, if you want to say it with a big word, big term, it's called post-tetanic accentuation. And patient will also have dysautonomia because those voltage-gated calcium channels are also located at autonomic nerve endings. Okay, so yeah, I'm just going back to the treatment. Oh gosh, investigations. Why? I don't know why I am in rush. Investigations, yes. So voltage-gated calcium channel antibodies, of course, we're going to study that, and we will do nerve conduction studies, okay? So if you could recall, in myasthenia gravis, we saw a decremental response with repetitive nerve stimulation, okay? So this condition is a bit different to that. When you do repetitive nerve stimulation, you're going to overcome, okay? So because you're going to send down the action potential, a lot more action potentials with the nerve endings. Voltage-gated calcium channels will work, and there will be lots of like acetylcholine vesicles stored in the nerve endings. They will be released, okay? And there will be significant increase in the output, okay, by more than 200%. And then you get the diagnosis, which is lumbar eaton myasthenic syndrome. Most of the time it's associated with cancer. So we also send for other paraneoplastic antibodies. So when this antibody is positive, it's called anti-SOX1. And then the likelihood of a patient having cancer is very high. So you really need to do a thorough, okay, a thorough and persistent hunt for cancer, okay? So management, we're going to come to it now. So it's because of cancer, isn't it? So you need to get rid of the root cause, which is treatment of cancer. Okay. Meanwhile, you also want to get rid of like those antibodies. So again, you give IVIG, you can try and flex. There is a particular medication called 3,4-diaminoparidine that can also be given here in this case. So this is the medication. So the concept here is, so you also have voltage-gated potassium channels, which are important to sort of stop the action potential, okay? So by blocking those potassium channels, what's going to happen is action potential, okay? So that can be prolonged. And when the action potential is stronger, what's going to happen is, so they will overcome the voltage-gated calcium channel antibodies, and then patient will have more acetylcholine vesicle release into the neuromuscular junction, and then the strength will get better. You can also use pyridostigmine in this condition as well. So what time is it now? Okay. Okay. Oh. So so I will talk about like another 15 minutes, if that's all right. Paraneoplastic syndrome due to C. Langer. Excellent. Yes. Well done. Oops. So yeah, I am going to yeah, this concept is very important for diagnostication, not concepts, there are two concepts. So Occam's razor, so that William of Ockham is a monk, actually, a monk in like 13th century. So he said, don't complicate matters, okay? Everything can be explained by a single root cause, okay? So for example, if you have lots of symptoms, you cannot figure out what's going on. Okay, it's like a jigsaw puzzle, but when you put things together, it's going to appear as an elephant. Yes, elephant is responsible for everything. Okay, so if a patient has lots of symptoms, you see, in the end, yeah, it's going to be one condition that's responsible for all the symptoms. That's a concept of Occam's razor. And then this physician, I think he was a bit sarcastic, perhaps. So he is an American sort of physician. So in the 1950s, he said, don't be bothered about this Occam's razor, okay? Patients can have as many diseases as they damn well please, okay? So that's what he said. So that means when we're trying to tease out the symptoms, we cannot pinpoint one particular condition. And then you might well think, oh, perhaps this patient is too unfortunate to have more than one condition, okay, which are responsible for patient symptoms, okay? Sometimes we need to think differently, okay? So that's about Occam's razor, and here comes dictum, okay? So case 4. So this is going to be a bit difficult, okay? So you can just listen to it like for pleasure, okay? So you might not know the answer, that's all right, but you can listen. This is a real scenario from for my department. Okay, the case for a lady in her late 30s with grade 2 astrocytoma in right frontal lobe with previous craniotomy and debugging and radiotherapy, chronic kidney disease, hypertension. She was admitted with abdominal pain. So that was treated as sort of like suspected appendicitis. So during the hospital admission, what happened was she developed malignant hypertension, and she also had acute kidney injury, and that was followed by seizures. She was known to have seizures anyway because of this astrocytoma, so because of this brain tumor, okay, brain tumor. So we thought, okay, yeah, she had appendicitis. Unfortunately, yeah, her hypertension is uncontrolled during the admission. With malignant hypertension, you can have a condition called this posterior reversible encephalopathy. That's why a patient had a lot more seizures. So that was the first explanation. Okay, so that all can be explained by this brain tumor. So this is our brain tumor. Okay, so this is the press, the posterior reversible encephalopathy. So when you have malignant hypertension, when blood pressure sort of like shoots up, like let's say 250, what's going to happen is there will be increased vascular permeability, the vessel damage, okay, to the occipital lobes, and patient will have confusion and seizures, etc. The treatment is just symptomatic. You treat AKI, you treat hypertension, you give some anti-epileptic medications, and then patient will get better. Those will be resolved, which also did happen in patient. So AKI fully resolved, press-like changes, fully resolved, and then seizures became like well controlled. However, she became encephalopathic. She became confused suddenly, and then she went into rapidly progressive flaccid cardioparesis, and during which she was also noted to have tachycardia at rest. So at rest, right, our autonomic nervous system, the way it works is if at rest, if you're not doing anything, yeah, if you're relaxed, what's going to happen is your heart rate is normal, okay, but this patient has got tachycardia at rest, so that's a sign of dysautonomia. We try to look for alternative causes. Did the patient have, okay, so worsening of astrocytoma? No, that wasn't the case. The patient didn't have any worsening of astrocytoma. And we checked metabolic markers, kidney function test, liver function test, etc. All were normal. She had cranial radiation, so we thought, oh, could it be because of pituitary hypopituitarism? Yeah, so it's because the patient is feeling like not well. So that's also not the case. We did EEG, electroencephalogram, okay, to check whether she has sort of clinically undetectable, yeah, we call subclinical seizures. And again, she didn't have any seizure activities on EEG either. And then we were thinking like, oh, this patient, you see, she had been quite unwell for a while, had been, you see, in bed. So could it be critical illness, neuromyopathy? So one, we don't use like nerve and muscles. What can happen is it's like use or lose policy. So if you don't use it, you lose. So we thought it might be critical illness, neuromyopathy, but she had been ambulant. She had been like mobilizing, and this is quite like sort of sudden weakness. So we're thinking, oh, look, these all the symptoms cannot be explained by a single condition. Like it is not Occam's razor. Could it be Hickham's dictum? Okay. And then we reviewed all the symptoms. This lady, for unknown reason, she has suffered from hypertension. She suffered from chronic kidney disease. This time she presented with acute abdominal pain. She had AKI, and then she also had seizures. She had peripheral neuropathy with dysautonomia. Okay, so what do you think is happening here? What condition you might consider in this scenario? Kidney function is absolutely normal. So she doesn't have diabetes. Okay, so it's not going to be DKA. MS is central nervous system neuroinflammation. Yeah. So this lady, yeah, So medicine is all about pattern recognition, isn't it? TOTS paresis. So TOTS paresis means patient had a seizure followed by weakness. So usually a seizure, you see, if it is focal, it's going to start from one side, isn't it? So TOTS paresis is usually unilateral, so either left side or right side, etc. So hepatic conditions, liver function test, also absolutely normal. Okay. Infection, good thought. We thoroughly searched for infection and it was also normal. Systemic sclerosis. Good thought. Well, it can cause sensory ganglionopathy. That's a very good thought. Which can cause weakness, but mainly ataxia. But this lady, she did have weakness rather than like incoordination. And I don't think systemic sclerosis can cause dysautonomia. Yeah, that's a very good thought. You see, she had abdominal pain, you see, which was thought to be due to appendicitis, but vagus granulomatosis. That's also another good. So for vasculitic neuropathy, okay, so it is multifocal, so it's not like sort of symmetrical. Anterior spinal artery stroke. That doesn't give like sort of other symptoms. So there is abdominal aortic aneurysm. Well, again, yeah. So it is very difficult to put together. You see, to have cause all the symptoms combination. So I'm just going to give you a clue. Okay. Does anyone know about medical causes of acute abdominal pain, which is a very, very popular, okay, bedside question when I was a medical student. ADKA. Okay. Anything else? PUD is, I think, surgical cause. Inferior amine, perfect. Anything else? Come on, you're getting there. IBS, basal pneumonia, perfect. One more, come on, one more. Appendicitis is gallbladder surgical causes, no cheating here, those are surgical causes. Medical causes of acute abdominal pain. If you watch House series, yeah, in one series, a patient was admitted with abdominal pain, yeah, and she started having seizures. And somebody, oh no, it's not in Doctor's House, but probably Grey's Anatomy. So anyway, so somebody asked a nurse to give IV fluid. Sickle cell disease, yeah, that can also happen, yeah, with splenic infraction, etc. That's also medical cause. And then somebody gave glucose, yeah, somebody gave intravenous glucose and symptoms went away. So the seizure stopped, abdominal pain got better. What is that condition? You're just missing one cause, you're very close, okay? What is that condition? It is associated with heme metabolism. Heme metabolism, hemoglobin metabolism. That can present with lead poisoning. Yeah, that's also another cause. Yes, that can also cause acute abdominal pain. Anemia, nope. Heme metabolism, porphyria. There we go. Well done. So acute intermittent porphyria. I think there is a box, isn't it, in Davison's Principles and Practice of Medicine? Okay, causes of acute medical causes of acute abdomen. Okay, well, I cannot remember. So yes, so this lady, so a brilliant consultant, yeah, it's not me. So she thought about this and then she sent for porphyria screening and it came back as positive. Okay, so acute intermittent porphyria. So this lady is, to be honest, she was very unfortunate, isn't it? So she had this astrocytoma, and unfortunately, yes, unfortunately, she also had this condition. So this is a good story about here comes dictum. Okay, so acute intermittent. So treatment, you give heme arginine infusions, and you sort of like give symptomatic treatment. Okay. So this is going to wrapping up. Okay. So acute neuromuscular weakness was acute neuromuscular weakness. One, the structures I mentioned here are affected. Okay, the motor neuron, neuromuscular junction, and the muscle. So I'm just going to briefly describe about the rest of the conditions I didn't mention, okay, so that you can get a full picture. So Andrea Honsel, somebody brilliantly mentioned about poliomyelitis. That's true. Poliomyelitis can affect anterior horn cells selectively, okay, in spinal cord, can cause acute lower motor neuron syndrome, okay, flaccid paralysis, asymmetrical. And nerve roots and nerve, somebody mentioned about vagus, yeah, so eosinophilic vasculitis. So vasculitic neuropathy, patient might have or might not have like already diagnosed primary vasculitic or rheumatological syndrome, and then they will present with what we call multifocal mononeuropathies, as the name says. Okay, so patient will have weakness in different areas. Okay, so you cannot pinpoint to a particular location. So different attacks at different sites. And one very particular characteristic about vasculitic neuropathy is it can cause significant painful weakness. Okay, pain. If a patient is complaining about significant pain, and you need to think about vasculitic neuropathy. And diphtheria. So diphtheria toxin can attack myelin again, okay, and can cause demyelinating neuropathy. Okay, so when myelin is affected, it's most of the time it's reversible. Okay, you know other symptoms, perhaps you might know better than I do. Somebody mentioned about lead poisoning. Okay, so one of the medical causes of abdominal pain is lead poisoning. So well done to that person. So motor neuropathy, you will have blue gum lines, abdominal pain, and you check for sort of serum lead level. And neuromuscular junction, one condition I have mentioned is botulism. So you will think about botulism, number one, when there are predisposing factors. So for example, if a patient is IBDU, or if a patient had a deep wound, okay, infected wound, and if patient presented with significant muscle weakness, so, but the difference between botulism, weakness between botulism and Columbury syndrome, usually botulism is sort of like descending weakness, okay, descending weakness. AINDP is Columbury syndrome is ascending weakness, okay. And another difference is you look at pupil. If there is pupil dilatation, it's going to be botulism, okay. Columbury syndrome cannot have any effect on pupils. And autonomic changes, if patient has like very profound autonomic changes, like blood pressure going up and down, hypothermia, etc., tachycardia, arrhythmias, and then you need to think about botulism. And patient tends to be like systemically very sick. Okay, they tend to be systemically very sick. And botulism, okay, so neuromuscular, it sort of like binds to this presynaptic membrane, okay, neuromuscular junction. So an acetylcholine cannot be released, okay, from vesicles. That how the weakness happens, okay. And myopathy. So when a patient, when would we consider myopathy? Myositis, okay, when a patient presents with weakness. So patient will have just painful muscle weakness, proximal, and they do not have any sensory symptoms, okay? They do not have sensory symptoms at all. And when you do not, deep inner reflex is going to be normal. And then you can check creatinine kinase, it's going to be raised, okay? So that's why it's always worth to check creatinine kinase. It's not expensive, okay? It's a simple test, but if it is high, above 1,000, you need to think about myopathy, okay? The three common conditions of inflammatory myopathy, polymyositis, dermatomyositis. Another condition, just a brand new condition, is called statin-associated autoimmune myopathy. So one patient is on statin or had previous exposure to statin, atorvastatin, which is very commonly used, isn't it? So it can cause antibodies to anti-HMG-CoA receptor. and that can cause weakness. Okay, so mimics. What are the mimics? So acute myelopathy. So you might consider acute myelopathy. One patient has sensory level. Sensory level means for peripheral nerve problems. Okay, so the longest nerve is the nerves in legs. Okay, so the sort of like symptoms, the weakness will go up gradually, and when it sort of like reaches to the level above, let's say like knees, and patient will start having symptoms in hands. Okay, and that's how peripheral neuropathy sort of like behaves. But for myelopathy, what's going to happen is the symptoms will go up to the chest. Patients still do not have any symptoms in fingers, in hands yet. And then you will be thinking about myelopathy, okay? And then sphincter dysfunction and plantar upgoing, we need to think about myelopathy. But bear in mind, you see, flaccid weakness, if due to myelopathy, can also happen without, you see, profound upper motor neuron symptoms, because it can still be in spinal shock stage. So for a spinal cord problem, you see, to be able to give upper motor neuron lesion signs, it can take up to months. Okay, it can take up to sometimes like 6 months, 7, 8 months, etc. But the point is, you look at sensory level, sphincter dysfunction, and plantars. Okay, and functional weakness, they're going to have this. You're going to notice a lot of inconsistencies during among examination findings. Okay, neuroanatomy is complex, so sometimes I blame God for making it too complicated, but sometimes I'm very much thankful, okay, because patients wouldn't know neuroanatomy, so they cannot lie. Okay, they cannot lie. So Hoover sign is essentially, so the principle is if you're using like sort of contralateral muscle, so if you're using hip flexors, okay, so how you examine Hoover sign is you put another hand, okay, underneath patient's thigh, okay, while you're asking patients to flex the sort of like hip. You can also try it now, yeah, so by yourself. When you do that, you're going to see the tension, okay, in hamstring muscles. Okay, so muscles at the back of the thigh, the hip flexors are working. So that's normal. So that means you're putting effort, okay, to do the hip flexion. So in patients with functional weakness, they don't put effort. Okay, so that's why you're not going to have that kind of tension in hamstrings. One patient like sort of tries to flex his or her hip. So and then we call it Hoover sign positive. So sometimes patient will have like paraplegia, so weakness in both limbs. And then how you're going to test, what you do is you check for the spinal, you put your hand in patient's back, okay, to check the tension of the paraspinal muscles while you ask the patient to flex both hips. Again, you see, you can test by yourself. If you're trying to lift your hips up, you will feel the tension in your paraspinal muscles. If you don't feel it, and again, this is likely to be a non-organic sort of weakness. And you can also check sensory level. Again, sensory system is sort of like built in a very complex way. Patient won't usually, they won't know neuroanatomy, so they will just say like, oh, I don't feel anything up to the neck. But if you check the back, patient will have sensation. Okay, so in that case, you know that this is likely to be functional disorder. And there will also be lots of pointers. Okay, so for example, like they usually have been having like stresses in life or a job, you see, social life, etc., followed by sudden onset weakness, and you'll be thinking about functional disorder. Fine. Okay, what time is it now? Am I talking a lot? Oh gosh, okay. About 1 hour and 20 minutes. So this is the last one. Okay, this is just to check, okay, whether you sort of like got something from my sort of discussion today. Okay, so now let's do this test. Now type in one condition each that affect anterior horn cells, nerve roots and nerves, nerve endings, neuromuscular end plate, and muscle. Okay, anyone who can answer all those questions, I think is going to be a neurologist in future. One, polio. Okay, and number two, conditions that I mentioned in this discussion that can affect nerve roots and nerves. Vasculopathy, botulism, nerve endings, great. Polymyositis is muscle. Now somebody is missing neuromuscular end plate. Okay. Lead poisoning, excellent. Number 2, yes. Nobody has mentioned about neuromuscular end plate. Yes, myasthenia gravis, LEMS, perfect. Excellent. 4B, myasthenia gravis, excellent. Myasthenia gravis, excellent. Great, okay. So they're the useful resources, one of which you definitely perhaps you have in your bookshelf, okay. McLeod's clinical examination, old is always gold, okay, perfect. Every time you read it, you get something new, okay. So that's very good. And this is sort of like continuum journal, okay. So it's from American Association of American Academy of Neurology, okay. So what I'm telling you is this is all the resources that I rely on, okay. So this continuum journal is the best. Oxford Handbook of Neurology, yeah, I've got it, small book, but very concise and very useful. And Practical Neurology from ABN. Yes, so the last thing, okay, I know you're having a time where you're very frustrated because you cannot do a lot, you cannot go to medical school to attend lectures, blah blah blah, okay. I know it's a very difficult time, but don't lose track, okay. So sometimes if you take it from bright side, this window period is going to be an opportunity to improve yourself. If you're at work or if you're at medical school, I didn't have any time at all to learn. So when I was doing medical school, there was always an exam every week or every 2 weeks or every 4 weeks, and there is always pressure to get high grades or to get distinction, blah blah blah. So when I started working again, didn't have any sort of like time to study much. So the window I only had was 1 year period from the time I graduated, till I got here to UK. So that was just about like 1.5 years window, so where I had a chance to improve myself, okay. So this is a good time. You can learn a lot from internet, okay, so YouTube, etc., lots of resources, okay. So don't give free time to your brain, so that's not good. So 95% of the time you self-teach, okay. So only 5% depends on the lecturers, okay. So make use of this window opportunity, okay. Don't give up. The opportunity will come, but you need to prepare for it, okay. So thanks a lot for listening this long talk and for all the interactions, okay. I really enjoyed very much. You all are very brilliant, okay, like I said, yeah. And we must win. We're going to very soon. So if you have any questions, perhaps, yeah, I can wait for about 5 minutes.
Thank you very much, Amma. That was a brilliant and lovely teaching. So someone has just told us that. So I once, Amma, I once listened to your lecture epilepsy. I even remember your 007 dose for lorazepam use in status epilepticus. May I know where can we watch your other lectures that you had taught for UK for medical students? Thank you, Amma.
Well, okay. For UK medical students, we don't do Zoom at the minute. So it's quite like sort of ad hoc. So I don't really think they're recorded, I'm afraid. But yes, I can do more lectures on neurology. So I'll ask the organizers here if I can teach. Well, I already have prepared some of the talks, so I can always okay, do them again. Yeah.
Thank you. That would be brilliant. And yeah, everyone's saying thank you very much for your excellent lecture. Looking forward to your next lectures. Someone has asked what neuro book and medicine book is good to study.
Perfect. Okay, then. So McLeod's Clinical Examination, that's the best. Okay. And this Oxford Handbook of Neurology is also brilliant. So I just checked McLeod's Clinical Examination. Actually, it's free online. Okay. Somebody uploaded PDF file. Okay. So you can get a PDF if you have internet. Okay. And this book is really good. Very concise. Okay. Very concise. So before I started working as a neurology registrar, so I finished this book. So it was always in my bag for about 2 years. Okay, so the best. Okay, yeah. And if you want to read further, Continuum. Okay, so this journal Continuum is the best. And Practical Neurology. This is from US, and this one is from UK. Okay. Well, yes. Okay. Somebody asked about.
Yes. So someone has asked, myasthenia gravis has role of steroids, but not in Columbury syndrome. Can you explain a little bit?
Oh, well, that came from sort of like studies. Okay. So I cannot remember the exact name of studies. So yes, so from those studies, they tried steroids in Columbury syndrome patients, and that didn't work. Well, perhaps because you see, for Columbury syndrome, you can also think that way. So Columbury syndrome is a monophasic illness, right? So it doesn't sort of like leave any sort of memory, okay, memory in a patient's immune system. So steroids, you see, most of the time it cannot give effect straight away. It takes some time. So it has sort of immune regulation effect by suppressing sort of lymphocytes. Okay, so lymphocytes production and lymphocytes function. So one GBS is a monophasic illness. One you need to, you see, give the effect straight away like that. So it wasn't a winner, perhaps. Okay, but that definitely came from a study or studies. Okay, hopefully that explains. Any further questions? This is Cancoma. Okay, Juju. What is cortical depression?
So they ask, can coma occur due to cortical depression with brainstem intact, or by what mechanism? Or...
So, well, the only thing I can explain is, you see, one, you have cortical damage, and one patient usually has sort of like for example, okay, so one mechanism that I can think of is if a patient has global encephalopathy, okay, from that cortical damage, okay, or if patient has continuous seizure activity, okay, from non-convulsive status epilepticus, perhaps patient will be in subconscious status. Most of the time, brainstem is involved in maintaining conscious level. So that's the only thing I can explain. Yeah, so meningitis or encephalitis, when there is global, you see global cerebral dysfunction. In that case, yes, so patient's consciousness can go down. And that always, you see, you also always need to think about epileptic activity in brain, or frequent or continuous epileptic activity in the brain as well. So when a patient with meningitis or encephalitis also usually has reduced consciousness.
And someone has also asked, what is fatigable weakness?
Fatigable weakness, okay. So fatigable weakness is, so you're seeing a patient, let's say, yeah, so you check the muscle power, okay, at the start of the examination, and muscle power wasn't that bad, for example, like 4, and then you ask the patient to do repetitive movements, okay. So what you're doing is, I'm just going to show, yeah, so this neuromuscular junction image. Okay, so when you ask patient to do repetitive movements, so what's going to happen is you are exhausting acetylcholine, okay, at neuromuscular junction. You're using all the available acetylcholine, okay. Then after about 20 times, you check the muscle power again. So by that time, patient has already used up all the acetylcholine, okay. So, and then when you check the muscle strength, it's significantly reduced, okay. So before that, muscle power was, for example, like 4 or even like 5 minus, but after repetitive movements, it became like 2, yeah. So, and that's fatigable weakness, okay. And the same with fatigable ptosis or fatigable dysarthria. So what I normally do is, to be efficient, you ask the patient, okay, to look up, okay, at the finger, and you ask the patient to count aloud at the same time from 1 to 30. So you're listening to patient's voice and as well as clarity. So it will be less clearer and clearer, okay, towards the end. And the voice will also be like sort of softer and softer. And if patient also has extraocular muscle involvement, what's going to happen is the eyelid will also like droop, okay. And if you ask the patient to look at the finger again, they might see 2 fingers, okay. So that's how we check fatigable signs, okay.
Okay, thank
Does that explain? Yeah, I'm not sure.
So thank you very much ပါအမဟုတ်ဟို time လေးနည်းနည်း overshoot ဖြစ်နေတော့
ဟုတ်တယ် over တော်တော် shoot သွားတယ်နော်
ဟုတ်ကဲ့
sorry
ဟုတ်ရပါတယ်
hope we
ဟုတ်ကဲ့ thank
it's
you
a big
very much
topic
ပါဟုတ်ကဲ့
as I see you later though
thank you ပါအမဟုတ်ကဲ့
be safe